I would like to give a brief thing about this online series to Dr. Hamid first. That, sir, we have this online lecture attendance of about 50 to 50 participants, and our participants are from different countries. So usually the format is in English, and after your lecture will stop or finish, we will get the e-certificates, and those who fill in the e-certificates, they will get they will fill in the feedback form, and then they will get the e-certificate. But before the e-certificate, the question and answer session will be taken by you. And I welcome Dr. Hamid to online lecture series. This online lecture series we had started last year, and now we are towards the end of the series. After the next lecture, we will be moving on to our regional speakers and also the international speakers. So Dr. Hamid, I would like to invite Dr. Hamid to on today's lecture. Dr. Hamid was the president of PSA from 2000 to 2022. He's also the diplomat in American Board in Anesthesia. He is the pioneer in pediatric cardiothoracic anesthesia at AKU, and also the first one to establish the acute pain service in Pakistan, starting from AKU. So I welcome Dr. Hamid online, and sir, kindly please proceed with your talk. Thank you for joining.
Thank you, Dr. Asma. So the topic I'm going to cover is updates in thoracic anesthesia. It's a big topic, but I will try to cover within an hour. All right, so this is what we are going to discuss: anatomy and physiology, because it's very important to know the anatomy and physiology particularly for thoracic anesthesia. Lateral decubitus position, which most of the surgeries are done in lateral position, preoperative assessment, one lung ventilation, and post-op pain management. So let's start with anatomy. Before that, thoracic surgery has a higher mortality, about 3 to 4%, and high morbidity as well. So respiratory complications are atelectasis, pneumonia, respiratory failure, and arrhythmias are also very common. If post-thoracotomy, atrial fibrillation is very common, and usually some of the patients, in some of the centers, they give certain drugs to prevent this atrial fibrillation. So looking at the anatomy, we know the tracheal length is about 11 to 30 centimeter. It has 16 to 20 rings. These are the cartilaginous rings, which are deficient posteriorly. So it helps you whenever you're doing a fiber optic bronchoscopy, it will help you in localizing your bronchi. Tracheal begins at cricoid cartilage, bifurcation at T6. The most important for thoracotomy patients in which you are using one lung ventilation is right bronchus. So right bronchus is more wide and diverge at about 25 degrees from the midline. And the left bronchus diverges about 45 degrees. So right bronchus is more straighter. And the most important thing about the right bronchus is that the right upper lobe bronchus, which takeoff of right upper lobe bronchus is about 2.5 centimeter from the carina as compared to left bronchus. So this is the carina, and right bronchus is over here. So it's about 2.5 centimeter from carina, while the left bronchus is about 5 centimeter from carina. So if you have a fiber optic bronchoscope at the level of carina, you should be able to see the right upper lobe takeoff. So we already know that right has 3 lobes, while the left side has 2 lobes. And apart from lobes, there are segments as well. So there are certain surgeries where they remove only segments rather than lobes. So the segments are 19 segments. The right one has 10 segments, and the left lung has 9 segments. So right lung is about 10% larger than the left lung. Little bit about mechanism of breathing. We know that during breathing, thoracic cavity changes volume. Inspiration mainly uses external intercostals and diaphragm. Expiration is passive at rest, but uses intercostals and abdominal muscles. during severe respiratory load. So, so during inspiration and expiration, thoracic cavity changes anterior-posteriorly and also laterally. Anterior posterior movement is called the pump handle movement, where the sternum moves up anteriorly, while laterally the movement is called bucket halter, where the movement of the ribs causes move upward and also laterally. That causes the expansion of the lung. Another thing to remember is that intrapleural pressure is negative and it becomes more negative at the end of inspiration. So as uh, at the end of inspiration, it's about -6 as compared to at the end of expiration, which is about -3. Another important concept of thoracic surgery is that that the pleural pressure is less negative at the basis as compared to the apex. In sitting position or upright position, the upper alveoli are usually open, and there is less capacity for these alveoli to contain more tidal volume. So most of the tidal volume is basically goes to the lower alveoli, which are during expiration, which are compressed by the diaphragm, and also the intrapleural pressure is less negative. So they have more capacity to expand, and their compliance is much higher. So minor increase is in pressure, which will increase the tidal volume much higher as compared to the upper one. So the upper alveoli have higher PaO2 because they are open all the time, but so that's why probably that is the reason the tuberculosis is also common in upper lobe. So apart from ventilation, the perfusion is also more at the basis. So if you look at the ventilation, it's about 0.24 liter per minute at the apex, and at the basis is about 0.82. While blood flow is minimal, about 0.07 liter per minute as compared to basis, where it is 1.29. So this leads to a ventilation perfusion mismatch. So ventilation perfusion mismatch is both at the apex and the basis, but the bases have more perfusion as compared to ventilation. So there will be some shunting of blood at the basis, while apex is basically the more ventilated than perfused area. So it's called a dead space. It's not a completely dead space, but there is some perfusion still there, but comparatively it's less as compared to basis. So in an upright position, the left lung receive about 40% of blood, while the right lung receive 55% of the blood, because it has more volume. As we already discussed, right side lung is almost 10% more as compared to the left side. In cases of right lateral position, when the patient, when you are doing a surgery on the left side of the thorax and the right side is dependent, then the blood flow will increase from 55% to 65%, while in the left lung, it will be reduced from 45 to 35%. And in cases of one lung ventilation, where you have deflated the lung, when the left lung is collapsed, then the perfusion is still there, it's almost 18%, while on the right side, it becomes 82%. So in case of left lateral position, during one lung ventilation, left side will receive 77%, while right side will receive 23% perfusion. This
Dr. Hamid, your voice has vanished and the screen has stuck to a point. I think the internet connection is interrupted.
Much higher.
Kindly, no, we can't see your screen. We can see you, but we cannot see your screen.
Let me share again.
Yes, sir.
All right. Yeah. Is it better now?
Yes, and I think we were on the previous slide before this one.
This one?
Yes, it was this. So can we have another, the one previous to this slide? Because
Okay.
I can't. Yes,
Is
the
it-
other one. Yes, no, we were on the second one.
This one?
Yes, indeed.
Okay. So as I was discussing about the perfusion of the lungs, so the right side get 55% of the perfusion, while left receive 45%. And in right lateral position, when the right lung is down or dependent, and the perfusion increases to 65%. And the left lung will receive less blood. So as the vessels are very thin, pulmonary vessels are really thin, and blood is basically moved down to the dependent area. So in the lateral position, the dependent area is the right lung. If you are doing a surgery on the left lung, then the right lung is the dependent or near the table. So it will get more blood as compared to the left side. And one lung ventilation, when you have deflated the lung, when the left lung is collapsed, then the right lung will receive more blood as compared to the left one. So another concept is West zones. These are physiological zones divided into 4 zones. Zone 1, where the alveolar pressure is much higher. So that's why the arterioles are constricted and where there is minimal blood flow in the apical region in the supine position. So this is called zone 1. Zone 2 is the area where arterial pressure is more than the alveolar pressure and there is some flow going on. But zone 1 and zone 2 are interchangeable. Zone 1 will increase. Zone 1 is basically a dead space where there is ventilation but no perfusion or minimal perfusion. So this zone 1 can increase in cases of hypotension and when alveolar pressure is much higher. When you put a lot of PEEP in a patient, then alveolar pressure will be much higher and zone 1 will increase and zone 2 will reduce. Zone 3 is the area which is basically the lung composed of most of this area, and here the alveolar pressure is much higher. Arterial pressure is higher than the venous pressure, and venous pressure is much higher than the alveolar pressure. So the capillaries are open all the time, and this is the area basically where you want to wedge your pulmonary catheter as well. So these are basically 3 zones. There are some concept, something that there are only 3 zones. There is no 4th zone, but something that there is a 4th zone in which is the interstitial pressure zone. Arterial pressure is higher than the interstitial pressure, and most of the fluid in pulmonary edema collected in this zone. So this is the upright position. But when you move the patient to the lateral position, where one lung is dependent and the other one is non-dependent, then the blood will move down to the dependent area of the lung. So the zone 3, this is the zone 3 and the upper one will be the zone 1. Again, the same concept. Zone 1, where is basically a dead space where alveolar pressure is higher than arterial pressure. Zone 2, arterial pressure is higher than the alveolar pressure. And then zone 3, which is the most dependent area of the lung, where where the blood supply and the perfusion is the most in this position. So this is very important for VQ mismatching. So we know that the perfusion is mainly on the dependent region of the lung. So what about the ventilation? So the ventilation in awake patient, even in the lateral position, there is enough compliance of the dependent lung and the VQ mismatch is minimal. But when the patient is anesthetized, the compliance curve will move to the non-dependent regions. So if you give a tidal volume to an anesthetized patient, it will mainly transfer to the non-dependent lung, not the dependent lung. So the dependent lung is still getting more blood, but the ventilation is less in lateral position under anesthesia. So the compliance of the dependent lung, which was over here in the middle with the minimal change in pressure, volume increases, but under anesthesia, dependent lung becomes more compliant as compared to the non-dependent lung becomes more compliant as compared to the dependent lung. So there will be more and more ventilation perfusion mismatch, and you will see hypoxia and other effect. So that was the physiology. Now, what about preoperative assessment of a patient who is coming for lung resection? So the basically spirometric test and all the tests are necessary except in those patients who are asymptomatic non-smoker patients and surgery does not involve lung resection, then the spirometric function is not really important. But if patient is coming for lung resection, then the assessment of the lung resection needs to be done, whether this patient can be have a lobectomy or pneumonectomy, so that this patient cannot be dependent on ventilation and can be safely extubated at the end of surgery. So there are different tests. The first test, you would do the spirometric test, look at the FEV1 and DLCO. FEV1, if it's more than 2 liters per minute or more than 60% of predicted, then there is no need for further testing. You can safely send the patient for the surgery. But if it's less than 60% and DLCO is the diffusion capacity of carbon monoxide. So if it's less than 60%, then you have to go for other tests, which are predicted post-operative FEV1 and predicted post-operative DLCO. If it's more than 40%, then go for surgical resection. Otherwise, further testing is necessary. Further testing is basically cardiopulmonary testing, where you would look at the VO2 max, and we are going to discuss this further. So this is the basically the whole analysis how you do assessment for lung resection. So they initially started with respiratory mechanics, percentage of predicted volume corrected for age, sex, and height, FEV1, FVC, MVV, and post-operative FEV1, and other things like DLCO. DLCO is basically diffusion of carbon monoxide, and it basically look at the capillary and alveolar membrane function. So other cardiopulmonary tests are stair climbing test. You will ask the patient to climb about 2 flights of stairs and look whether he can achieve that or not. 6-minute walk test, rapid walk for about 6 minutes, but the rest is allowed in this one. Shuttle walk test, back and forth in 10-meter distance. And also you apply a pulse oximeter to a patient and ask him to climb a stair. If there's a drop of more than 4% saturation, then it means patient has some issue, it needed further testing. But all these 4 tests are not really standard tests, and there are no standard numbers through which you can say that these tests are positive or negative, or these tests are enough. So the best test for pulmonary function is the VO2 max VO2 max is the oxygen capacity of the patient, whether how much extraction of oxygen body is taking during exercise. If it's more than 20 ml per kg per minute, then it's called the low risk. If it's moderate, 10 to 20 ml per kg per minute, and the risk is very high if it's less than 10 ml per kg per minute. And basically, these patients should not go for resection surgery. This is how it is done. It has different gauges. ECG is also attached, and there is a mask which look at the oxygen concentration patient is getting, CO2, tidal volume, and all these are done with different exercise schedules. It can be done in the treadmill as well. So that this is the best test which will give you an idea whether the thoracic surgery can be performed and what kind of surgery, whether lung part of the lung can be resected or not. This is the best test for cardiopulmonary function. Even the cardiac function can also be assessed with this one. So the risk for poor outcome are those patients who have PaCO2 more than 45 millimeter of mercury on room air, PaO2 less than 60 on ABGs, PFTs, FEV1 less than 2 liter per minute, and predicted postoperative FEV1. Predicted postoperative FEV1 is basically the FEV1 you can get after surgery. But it can be predicted preoperatively by there is an equation which can be used to predict what would be the FEV1, and it depends on how many segments or lobe you are going to decide. And then maximum VO2, which is less than 10 ml per kg per minute. So this is the usual position, lateral position done for thoracotomy patients. The upper leg should be straight, lower leg should be flex, and there should be a pillow in between. And there is an axillary roll, which should be away from the axilla actually. So this is how you're going to prevent any kind of nerve injury or pressure injury in this patient. So about lung isolation, there are certain indications about lung isolation. Lung isolation is required to prevent the spillage of infection or hemorrhage from one lung to the other lung. For example, abscess on right lung, you want this abscess to contain over there or remove rather than spreading to the other lung. Differential ventilation like bronchopleural fistula, bronchopleural cutaneous fistula, unilateral cyst, and bronchopleural disruptions. Another is unilateral lung lavage. This is about alveolar proteinosis, where one lung is ventilated and other one is lavaged and remove all those alveolar proteinaceous material. Another indication, this is a relatively new indication, absolute indication, is video-assisted thoracoscopic surgery. And then there are other relatively relative indications like upper lobectomy, esophagectomy, and all those. Those are not absolute indications. So how to achieve lung isolation? You can achieve lung isolation by using a single lumen tube. There used to be endo tubes, which particularly designed for this kind of surgeries. Here you insert this tube blindly into the right or left lung, and then the surgery is performed on the other lung. This is particularly done in still done in the pediatric patients. The other is bronchial blockers. Bronchial blockers are basically a small catheter-like, Foley's-like catheters. Foley's catheter has also been used as a bronchial blocker in thoracic surgeries. Fogarty catheters, and there are other catheters which can be used as a as a tube to block a particular lung. The disadvantage of these blocker is that the deflation of the lung is very slow, and also you cannot suction out the secretion of blood from that area. But the advantage is that it can be placed into a particular lobe or particular segment, and you can block that segment rather than blocking the whole lung as you do in double lumen tubes. So these are different bronchial blockers, and different companies actually have different blockers. The last one, the most right one, is called the easy blocker, which reside at the carina, and accordingly you can inflate right balloon or left balloon and deflate the lung accordingly. Another blocker, this is a single lumen tube with the blocker built in. It's called a univent tube. Blockers are usually passed after putting a single lumen tube, and the blocker is put in through the tube, and also fiber optic bronchoscope help in placing the blockers in a segment or the lobe, or if you are blocking the whole lung. So the important thing about isolation is the double lumen tube actually, which is most commonly used. Blockers are relatively less commonly used because of the price and also need of fiber optic bronchoscope, while the double lumen tube is more commonly used. So if you look at the double lumen tube has two curves, and this is the one curve and the other one is this one, and then two balloons. The distal balloon is usually blue in color, while the proximal balloon is transparent, and two pilot balloons, and also two tubes. So the bronchial one is usually blue in color, while the tracheal lumen is usually transparent in color. So this is how you place a double lumen tube, and you can collapse, for example, right lung in this case, and put a left-sided double lumen tube to ventilate only the left lung, and surgeon can perform surgery on the right side. So tubes are also two types, right side double lumen tube and left side double lumen tube. This is usually asked in the FCPS exam as well. So you should know how to know which one is left and which one is right sided double lumen tube. So for example, on my right side of the screen, that is the right side double lumen tube, and the left side of the screen is the left sided double lumen tube. So the right side basically has a slot for right upper lobe bronchus ventilation. So there is always a slot available on the right side, while on the left side of the tube there is no slot for left bronchus, left upper lobe bronchus ventilation. So how you're going to find out which one is left and which one is right? The first thing is look at this first curve. This curve, if hold the tube and see if this curve should be towards the ceiling, and look at the tip of the tube. If it's on the left side, will be a left-sided double lumen tube. If it's on the right side, it will be a right-sided double lumen tube. So the other finding would be a slot for right upper lobe bronchus ventilation in the right side double lumen tube, but it won't be there in the left side double lumen tube. These are different tubes. For example, the upper one has three cuffs. So in between two distal cuffs, there is a slot for ventilating right upper lobe. This one is donut shape balloon, and there is a slot there, and also there is a slot there for ventilation. Another tube which is now available, but it's costly, so it's not available everywhere. It has a built-in camera, and you can attach it to a monitor, and you can see the progress of double lumen tube when you are inserting it. So how to select a double lumen tube? Non-operated bronchus should be routinely intubated. Right upper lobe takeoff is high, and there are considerable anatomic variations. So the size of lumen tube usually for females 35 to 37 French is enough. For males 39 to 41 French. This French is different from the single lumen tube internal diameter and outer diameters, which are in millimeters. So for male, if a patient has a height of more than 170, usually the tube size is used 41, while the 37 can also be used in less than 160 centimeter height. For females, you start with 37, you can go down to the 32. 35 is most commonly used in female patient. So the tube size is available from 26 to 41 French. And this you can also identify by looking at the X-ray. And X-ray, sorry. आवाज आ रही?
Yes, we can hear you.
Yes, sir.
Hello.
आवाज आ रही है कि वेट चली?
Okay.
Yes, we can hear you, Dr. Hamid.
Okay. So according to the X-ray, you can look at the diameter of bronchial diameter. If it's more than 12 or more than 12, then you can select a double lumen size of 41, and accordingly, you can choose your double lumen size. So if you take a cross section, you will see the double lumen tube is D-shaped. Both lumens are D-shaped. This one is the 41 as compared to the 10 single lumen size tube. So this is a cross section. So when you are inserting a double lumen tube and you have deflated the lung, there is another factor which comes into action is the hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction is actually when you deflate a lung, the alveolar oxygen concentration will reduce, and that will cause constriction of the pulmonary artery. This is a defense mechanism in which you are now diverting the blood from the one lung to the other side or the dependent lungs. So which is good for the patient as well. So the more ventilation and more perfusion is going to the dependent lung. But these can be affected by factors like vasodilators. If you are giving glyceryl, trinitrate, nitroprusside, dobutamine, calcium channel blockers, all these will abolish this HPV effect, and these patients will have problems like hypoxia. Vasoconstrictors can also cause problem, hypocapnia, hypothermia, but there is minimal effect by inhalation agents. So inhalation agents can also be used. So this is called hypoxic pulmonary vasoconstriction. You should know the effect and the factors which can affect HPV or hypoxic pulmonary vasoconstriction. So how to ventilate a patient? Once you have inserted a double lumen tube and it's ventilating properly, so what should be done? It should be a lung protective ventilation. This is basically a new concept. In older books, it was mentioned that larger tidal volume should be delivered to the patient, about 10 to 20 ml per kg, 100% oxygen. But with the new concept, lung protective ventilation should be used, 50 to 100% FI to low tidal volume of about 4 to 6 ml per kg of ideal body weight, and apply PEEP initially with the application of one lung ventilation. And intermittently, you can do recruitment maneuvers like applying a positive pressure and for 30 to 40 seconds, and then increasing the PEEP. Pressure control ventilation can be helpful in increasing PO2, but not much. There is not much difference in different studies. So in case of hypoxia, agar hota hai, what should we do in case of hypoxia? Make certain that hypoxemia is real. check your pulse oximeter, patient's color, give 100% oxygen. If you're not giving 100%, assess compliance and ventilate the patient, check the position of double lumen tube, look at the marking at the teeth, and confirmation is by fiber optic bronchoscope. If you have fiber optic bronchoscope, this is the best thing you can do in the patient with one lung ventilation. Fiber optic bronchoscopy most useful to check the position, it help in removing the secretion and evaluate the obstruction. So this is the position where you can see the left side double lumen tube has been used, and with the help of fiber optic bronchoscope, you can see the right bronchus, and in the left bronchus tube is going with the upper part of the blue balloon can be seen. So this is the blue balloon. If you can see the upper part, then it means your position is perfect. So now how you can escalate your PEEP in the dependent lung from 5 to 6, 7, 8, you can go up to 10 or more. And in the if it's still an issue with hypoxia, you can give non-dependent lung oxygen or CPAP of about 5 to 10 centimeter. And if it's still not helpful, then you have to discuss with your surgeon and intermittently ventilate the 2 lungs. And if patient is doing a pneumonectomy and is close to a pulmonary artery, you can ask the surgeon to clamp the pulmonary artery. That will reduce the shunt and patient's saturation will improve. But during this process, assess hemodynamic status of the patient as well. So this is the CPAP apparatus. Here you can see that patient is there is single ventilation, and because patient is having hypoxia or decreased saturation, so they have started applying CPAP. So this is the CPAP apparatus which is available. You can even put a catheter with and oxygen directly into the tube, and that sometimes help as well. So this is the diagram of that same CPAP system. So when you insert a double lumen tube, it can be a correct position. It can be too far in. If you are using a smaller tube, usually you may push the tube too far in, then you will have issues. Or it may be too far out, not deep enough. In that case, both the balloon will be in the trachea, and you will not be able to ventilate the patient. And you will be able to ventilate the patient only when you are ventilating with the bronchial lumen. That won't be enough for such patients. And the third thing which can happen is that you may have insert the left-sided double lumen tube into the right side. Most of the commonly left-sided double lumen tube is used. So if you insert it on the right side, then you will have blockage of the right upper lobe bronchus. So the right upper lobe you will not be able to ventilate right upper lobe. Only the middle and lower lobe will be ventilating if you are ventilating through the bronchial lumen. So the last part of this presentation is pain management. Pain management, I think this is the thoracotomy is the surgery which causes the most excruciating pain. The most pain a patient can feel during any kind of surgery. So the pain is usually due to different reasons. It may be a somatic pain, like thoracic wall incision, where surgeon make an incision that is the site for pain. Disrupted costochondral and posterior rib, because they use retractors, and retractor causes disruption of costochondral junction. Compression of the dependent shoulder, because the patient is on left side or right side, so the dependent shoulder pain is quite common. Rather, sometimes you will see only the patient complaint is basically on the left side or right side, is shoulder pain only. The other thing is visceral pain, pleura and diaphragm pain can also be part of this pain manage. It has to be part of pain management. Then sometimes you make sure that every the surgical site pain is covered, but not the chest, not the side where the chest tube was inserted. So the chest tube pain has to be considered as well. And there are some muscle spasm of the thoracic and abdominal muscles as well. So it's not only the surgical incision which causes pain, but the other areas which are also involved in this pain. So the pain management can be done by intramuscular, epidural, intravenous, peripheral blocks. But the gold standard is still thoracic epidural, which should be inserted in all these patients because of the pain, because of the severe pain, rather. Now the new blocks are coming up, like paravertebral blocks, extrapleural, intercostal, intrapleural blocks. But the new blocks, which are rectospinal block and serratus anterior block, these are also helpful in thoracic surgery patient. Out of these intrapleural blocks are basically useless block because you put us chest drain in that area, and whatever drugs you give in the intrapleural space, all these drugs will come out unless you block chest tube. So other rarely used are patient control, epidural analgesia, subarachnoid, TENS, cryoanalgesia. All these have been used. But recently, basically, people are using thoracic epidural, intravenous continuous or PCA, and all these peripheral blocks. Paravertebral are very common in these patients. So about lumbar, about epidural anesthesia, lower thoracic are basically used for abdominal surgery. So it's better to use upper thoracic region, mainly 5 to 6, between 5 to 6 thoracic vertebra is the better place for epidural insertion rather than going downwards in the lumbar or lower thoracic region. And when you're inserting an epidural catheter, surface marking is very important. For example, the inferior angle of scapula is at the level of T7. So you should place your epidural catheter just above it, about around 5 to 6 or 6 to 7. And the approach can be midline or paramedial. Paramedial approach is usually more successful and much easier as compared to the medial approach because the shape of the spinous processes. Another thing, another facial plane is rectospinal plane block. You can do it in a sitting position before the surgery or in the lateral position. This is done under ultrasound guidance. Here you touch the tip of the transverse process with your needle and then inject drug over there and look at the separation of rectospinal muscle fascia from the tip of the spinous process, and you can give about 20 ml of your drug in that area. So this is the rectospinal block, rectospinal muscles, and then rectospinal between tip of the spinous process and rectospinal muscle fascia. Another one which we use in our hospital is extrapleural catheter, which is inserted by surgeons actually. It has advantage over epidural, less chances of bladder and lower limb motor function, less hemodynamic compromise, can be performed in ventilated patient. So here they peel off the parietal pleura and up to the paravertebral area. And then the epidural catheter was inserted in that area, and the rest of the epidural catheter is bring out by putting epidural needle and then putting the pushing the catheter outside. So this is how epidural this extrapleural catheter is placed. And then you can give 0.25% bupivacaine or ropivacaine accordingly, about 6 to 10 ml per hour. So in conclusion, the understanding of following is essential when you're dealing with thoracic surgery. It's very essential for anesthesiologists to know the airway anatomy and lung physiology. You should know the right upper lobe bronchus position. You should know the perfusion, which is always high in the dependent region, while the ventilation can be changed according to the anesthesia. Physiological effect of lateral decubitus position, preoperative assessment and optimization. So the best tests are predicted post-operative FEV1, predicted post-operative DLCO and VO2 max. Rather, VO2 max is the gold standard for lung resection surgeries. How to achieve and manage one lung ventilation? You should know how to insert a double lumen tube and the bronchial blockers, which patient bronchial blockers are helpful, and in which patient you will use double lumen tube, and what are the troubleshooting with all these equipment you are using. So the next is the modalities of postoperative pain management. We already discussed thoracic epidural is still the gold standard, but now the rectal spiny block and extrapleural catheter are more commonly used for the management of pains. But one thing you should remember, even the thoracic epidural and infusion are not the only management. You have to give them some kind of narcotics as well, because particularly the shoulder pain will not be covered by thoracic epidural anesthesia. Thank you. That's all.
Thank you so much, Dr. Hamid, for your elaborated and extensive talk on thoracic anesthesia. So first, I would like to have questions from my participants. If anyone has any question, can please ask Dr. Hamid now. So let me check the chat box. So Dr. Azhar is saying that in my experience, unilateral erector spiny plain block is very effective, easy to do with less complications and cover incision pain and chest tube as well, but needs ultrasound machine. So any comments on this?
Yes, I agree with Dr. Azhar. But we don't usually use erector spiny block. We are using extrapleural catheter, which is, I think, as good as epidural and erector spiny block. I think the space is the same actually. It's the paravertebral space, whether you are using the paravertebral block, erector spiny block, or this extrapleural block. The advantage of erector spiny block is that it also has some extension into the epidural space. So probably it may be a little bit better. But
in terms of covering the site of incision, or you are talking about the rest of the procedure which is being done?
I mean, it is a little bit better in terms of coverage of not only incisional side, but also the side of your chest drain.
All right.
But there are, let me tell you, erector spiny.
I can't hear you, Dr. Hamid.
Dr. Hamid, your voice has gone muted. So can you please unmute your mic?
Is it better now?
Yes, yes.
Okay. So there are not too many studies present on erector spinae block. So still, I think thoracic epidural should be considered as a gold standard, unless with time we will have more and more studies on the erector spinae block.
Right. So we have another question from Dr. Shahid. Dr. Shahid is from Sahiwal Medical College. And he's saying that adding PEEP during one lung ventilation increases the dead space ventilation. My question is it advisable to add PEEP during general anesthesia for routine surgeries where such advanced pre-op testing is not done routinely?
Sorry, what is the question? Adding a PEEP in general surgery?
No, he's asking that is it because during one lung ventilation, adding the PEEP might increase the dead space ventilation. This is his question, that if you add PEEP during general anesthesia for such surgeries where it is not done routinely. Dr. Shahid, can you please unmute yourself and clarify the question you have asked on chat box?
I think he's asking whether it can be PEEP can be applied in a general surgery patient. So
I think, sir.
I think so, yes. I think so, yes. He's asking about the general surgery and other procedures, other than the thoracic anesthesia.
Yeah, I think.
Dr. Shahid, can you please elaborate your question, please?
My question was, sir has rightly said, added PEEP during one lung ventilation increases dead space ventilation. Is it advisable to use PEEP during routine general anesthesia other than one lung ventilation?
You mean to say other than thoracic surgeries?
Yes, ma'am.
Okay.
Yes, I think it can be used. PEEP can be used with with the lower and lower tidal volume. Actually, people are not using 8 to 10 centimeter water pressures now. They are using low tidal volume, particularly in obese patient and patients like laparoscopic patient. I usually start with adequate tidal volume and also with PEEP.
So actually, it depends on the type of the patient and the patient's respiratory condition. So if a patient is undergoing any kind of general anesthesia, but not the thoracic anesthesia, and one lung ventilation is not being used, the indication of PEEP might be hypoxia or obesity or any other decrease in the lung compliance in which the PEEP is required, if I'm not wrong, Dr. Hamid.
Yeah. I think you can use PEEP, but you have to be careful with PEEP as well. For example, a COPD patient or patient with certain diseases like lung bullae, that can be disastrous for the patient. So you have to have a full evaluation and should be applied in selected patients.
Right. And what is the intraoperative position for extrapleural block? How much length of catheter is put inside? Please throw some light. This is by Mohammad Yusuf.
The catheter is actually done directly by the surgeon in the paravertebral space, and usually is under the pleura. It's about 4 to 5 centimeter inside, and the rest is outside, just like epidural catheter. In epidural catheter, you insert up to 3 to 5 centimeter maximum.
And this is being put by the surgeon, or can an anesthesiologist? Yes.
No,
so
not.
There's
it is
not
done during thoracotomy, when the thorax is open, and it is done by the surgeon directly into the paravertebral space.
So we have another. Sir, we have a few more questions. If that is sufficing the answer of Dr. I don't remember the name, Mohammad Yusuf. Okay. So there is another question by Muhammad Fawad, that how much dose and volume for extrapleural block?
How much dose and volume? We usually start with 6 to 8 cc. And once the patient is awake, and according to his condition, we can go up to 12 cc per hour.
And the percentage weight per volume?
We use 0.25%.
Okay. 0.5%?
0.25%.
That is half of the 0.5% of the BPP.
Yes, exactly.
Yes.
And the dilution is being made with normal cell line.
Yes.
Definitely, yes.
So we have two questions on pediatrics. One is by Dr. Asia and the other one is by Dr. Mohammad Idris, I think. So the question is, please share examples of one lung ventilation in the pediatric patients, and the other one is similar. Is one lung ventilation equally beneficial in children like other patients? It can be affected by dead space.
Yes, it can be done. Actually, we have done certain cases in which we use bronchial blocker, and in 4 or 5 years old patient. Double lumen tubes size which are available right now are 20. Smaller is about 26, which can be used up to the age of, I think, 8 to 9 year old patient. And under that age, you have to use a single lumen tube while pushing it to the right side or left bronchus, or you can use a double bronchial blocker, which is relatively thin as compared to double lumen. And this blocker is usually play in infant and a neonate. Actually, it has to be, this blocker has to be placed outside the single lumen tubes. So still you use a fiber optic bronchoscope and guide your bronchial blocker into wherever you want to place your blocker. So, but in our country, mostly single lumen is used, and single lumen is pushed into the one side of the lung, one side of the bronchus, and surgery is done on the other lung.
Sir, but most of the times in children, we when we don't have the adequate size of the double lumen catheter or the double lumen endotracheal tube, because it's quite easily done in the right side instead of the left side. So if we have to do the surgery on the opposite side, how would it be feasible for that tube to go in, and what are the difficulties which we can encounter during that?
So far, as I said, right upper lobe bronchus takeoff is about 2.5 centimeter from the carina. So you have to have a right-sided double lumen tube for that purpose. If you are doing a surgery, for example, left side, left main bronchus has some kind of tumor or hemangioma or something like that, you will not be placing left-sided double lumen tube in that patient. Then
Right.
you're using right-sided double lumen tube. So right-sided double lumen tube placement, you have to have a fiber optic bronchoscope.
And if by convention someone doesn't have a fiber optic at their institute, or then what can they do?
Then you have to place it blindly and see and auscultate the upper lobe whether you are ventilating it properly or not. Then you have to adjust accordingly. But fiber optic is
The key gold standard.
yeah, gold standard is fiber optic for placement of even left-sided double lumen tube.
So we have a last question from Mudassir Ali, and then I would like to take some comments from our seniors which are present here. Mudassir Ali has said that, sir, as you have said, PEEP should be avoided in respiratory diseases, especially having bulla. So PEEP should be avoided in COPD patients as well. This is his question.
Yes, we already discussed this, I think.
Yes. No, he's asking is that in COPD patients, shall we avoid giving the PEEP, especially when there is thoracic surgery going on?
If possible, or minimal PEEP should be applied.
Right. So we also have on board with us Dr. Amin Khwaja, who was ex-president PSA. And finally, I will take some comments from Dr. Shabbir Jumani before closing off. But I would request every participant to kindly fill in the feedback form in order to get the e-certificate. Dr. Amin, because you have been doing cardiothoracic anesthesia for a long time, would you like to please comment?
Yeah, thank you very much, Dr. Asma, and thank you, Dr. Hamid. Dr. Hamid has covered almost everything, starting from the physiology, anatomy, and ventilation. Then he also discussed about the pain management. I think thoracic surgery is done in quite few centers in Pakistan. And I don't know if everyone is using in double lumens or bronchial blockers, but standard of thoracic anesthesia is almost everyone is following those things. Regarding the pediatrics, unfortunately, we don't have the much less than 26, which can be used for the 6 to 8 years of the children. So the single lumen is the again answer for that one. And I think Dr. Hamid has covered everything. And I thank you, Dr. Asma and Dr. Hamid for Dr. Hamid for the lecture and Dr. Asma for continuing this lecture series. And thank you once again, Dr. Shabir, for supporting the event. Thank you very much.
Thank you, sir, Dr. Amin. And now I would like to have the final comments from Dr. Shabir Jumani, who is the current president PSA.
Thank you very much, Dr. Asma, for asking me to give my comments, and good afternoon to everybody. Practically and truly speaking, it was a kind of a refresher course for me, because I've limited myself to, as everybody knows, particularly orthopedic anesthesia, joint replacement surgeries. So it has been a long time, when I was practicing thoracic anesthesia, particularly for cancer surgeries. But now it was practically a refresher course for me, wonderfully presented, and the answers of the different questions were very, very concise and particular to the point, So congratulations, Dr. Hamid, for presenting such a nice presentation. Thank you very much. And thank you, Dr. Asma, for conducting this session beautifully.
Thank you so much. So
Thanks.
thank you so much, Dr. Hamid, for joining us online today. I conclude this session of today with the thanks note to everyone for joining us every time. Either the time got changed, but I would also like to have a request that if you want to continue the same timing on Sunday or Monday evening is feasible, kindly let us know in the feedback form. Or just email us on the email through which the e-certificates have been given. So I would like to have this feedback from all of you, that whether you want to continue the same timing on Sunday, same time 3 to 4, that's more feasible, or as we used to do previously, Monday evening 7 to 8 or 8 to 9 was more suitable. So kindly give us this feedback, and thank you so much, Dr. Hamid. Thank you so much. We would like to have you again later on. Thank you so much. Thank you.